Hello, everyone. We have about 2 minutes before we begin, but I just want to say good morning, and I thank you all for joining us today on this exciting presentation on Mischief, Mayhem, and Murder on the Midnight Express, Undesirable Activity During Sleep. My name is Alana, and I work in community health at Baptist Health South Florida. This presentation is a webinar style, so if you have any questions, please use the chat box or the Q&A box. Baptist Health offers a variety of free virtual exercise classes and programs. And for our weekly schedule, please visit our website at events.baptisthealth.net. And I put that website in the chat box for you. And with that being said, I would like to now welcome our speaker today, Dr. Timothy Grant. Thank you, Dr. Grant.
So thank you all for being here, whoever's here. I hope you enjoyed today's talk. We're going to be talking about, it's a funny title. I chose this because these are the types of cases that I see on a regular basis. And we're going to be talking today primarily about parasomnias. So what's a parasomnia? You know, I'm a sleep specialist, so I see all kinds of sleep disorders. I see sleep apnea, where people can't breathe well at night. I see insomnia. I see people who are too sleepy during the daytime. I see people who awaken during the night with funny things, and those are called parasomnias. And para is around, somnia is around sleep. So the definition of parasomnia is an undesirable activity, something strange that happens in or around sleep. And what we're going to talk about today are these cases that I see, that some of them are funny and some of them are entertaining and some of them are just terrifying, very, very, very scary. And yet, the gratifying thing to me is they're all very treatable. Every case that I'm going to show you today, I'm going to show a lot of cases that I've actually seen. So as they say on TV, I've changed the names and the images, but these are actual cases that we see as sleep specialists, and every single one of these patients has done well with a fairly simple, straightforward treatment. So let's talk about what are the different things that I see. So sleepwalking is a classic example of a parasomnia. It's something that you're doing at night that you really don't want to do. You want to be asleep. You don't want to be walking around. So sleepwalking is a classic symptom of a parasomnia. Sleep talking, we're going to talk about that a little bit. It's pretty non-specific, but I'll tell you about a case that I had that was very, very interesting. Sleep terrors, night terrors. What I'm going to tell you about all these cases, what's interesting is I have a lot of kids and a lot of grandchildren, and many of my kids and grandchildren have had several of these happen, of these instances happening to them, and they've all done well, fortunately. But this is a night terror, and I'm going to talk to you about that as well. So sleep eating, this is something that's fairly new, that's described in the literature. This is people who get up in the middle of the night and go eat something with typically no recollection that they've ever done it. They literally raid the refrigerator, they eat funny combinations, and they wake up in the morning and realize that they've eaten things that they shouldn't have eaten. So here's another thing, sleep paralysis. So sleep paralysis is where somebody's convinced that they're awake in the middle of the night. They've awakened, they think they're awake, but they cannot move. They feel paralyzed. So they're aware of their surroundings, they're convinced they're awake, they're looking around, and they feel that they can't move, like they're in a coffin. Their legs are paralyzed, their arms are paralyzed, they cannot speak, they cannot move, and it's very, very, very scary. But again, very treatable. So here's nightmares. This is a classic thing that we all think about as a parasomnia. So a nightmare, oh my gosh, I woke up with a terrible dream. Honey, don't worry, you're gonna be okay, go back to sleep, but it was terrible, and you remember that terrible, terrible dream. So we're gonna talk about that a little bit. A clown, oh my God, what could be more scary than a clown? I actually had somebody who dreamt that there were clowns underneath his bed, and those were his nightmares. So let's go a little bit further, and let's talk about violence. Later on in the talk today, I'm going to talk about several different parasomnias, but towards the end, I'm going to talk about people that did very, very, very frightening things at night. But again, they're very, very treatable. So violence in sleep is one of the things we don't like to think about, but oh my gosh, boy, that can be scary. But these are cases that I see quite frequently, and again, very, very treatable. Now, one of the things that I want you to remember in today's talk, we've had a lot of these different talks at different times in the last several months, and one of the things that I've talked about is sleep apnea. So what is sleep apnea? Sleep apnea means that as you go into deeper and deeper sleep, your throat becomes so relaxed that it closes off like a kinked hose. And in the back of the throat, it closes off. not enough air gets into your lungs, not enough oxygen goes to your brain, and your brain says, hey, 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 come on, you gotta wake up, you gotta wake up. So your brain gives you a battery jolt that's no different than being frightened to get you to start breathing again. And the reason that that's important for today's talk is those battery jolts can trigger parasomnias. They can trigger you to sleepwalk. They can trigger you to do something dangerous or violent at night. So often we look for sleep apnea because that's very, very treatable. So we'll talk about that a little bit. So let's go a little bit further. This is something that I talk about in all of my sleep lectures, but it's very, very important to understand what are parasomnias, why do they happen, when do they happen, and how are they treatable. So here's my teacher giving her little instructions. So let's talk about sleep architecture. Again, we've talked about this in different talks, but what happens when you go to sleep? When you go to sleep, you're sort of awake, you're drifting off into light sleep here. You can see those waves become a little bit slower as you go into the lighter and lighter sleep. And then you go into deeper sleep. Look at those waves. They're getting slower and slower and slower. And then you go into what's called deep, slow wave sleep. And that's associated with different kinds of movements at night and different kinds of things at night. But look at this. Then you go into the deepest sleep, which is called REM sleep, rapid eye movement sleep. That's when you dream. And your brain is very, very active. You're using more oxygen, you're using more sugar than you're awake, and your brain is very active. And look how similar that looks to the top. So wakefulness and REM, rapid eye movement sleep, look very similar. So let's go a little bit further. We've talked about this in other talks as well. If you look to the left side of the slide, that's when you start to go to sleep. And that's what's associated with slow wave sleep. And then as you drift later on in the night, you go into what's called REM sleep, rapid eye movement sleep. And all those red things along the top are rapid eye movement sleep. And as you go into dream state, further and further and further into the night, you have more REM, rapid eye movement sleep. But let's go and let's look at the first part of the night. So the first part of the night, remember that says you're drifting off into slow wave sleep, you're kind of light sleep, you have just a little bit of REM, maybe you dream a little bit, but you have more slow wave sleep. And so that's your slow wave sleep. So you're gonna have more REM, more non-REM parasomnia. So remember, REM, rapid eye movement sleep, is later in the night. This is called non-REM. And what's an example of that? Well, an example is sleepwalking. So what is one of the basic features of, think about your child. So one of my sons was a sleepwalker. I'll tell you a funny story. So my brother, when he was little, the classic story, I just had a patient who did the same thing. My brother, when he was young, came down from sleep, and my parents were having apparently a dinner party, and he slept walk into the living room, lifted up a cushion on a chair in the living room, went to the bathroom, peed into the chair as if it was a toilet, put the lid, the cushion down, and went back to his bedroom. And he believed that he was sleepwalking, I guess, and going into the bathroom and peeing into the toilet. But he peed into the chair. And that's kind of a funny example. But interestingly, I just had a patient who did the same thing. And one of the things, a classic covenant of that, is you don't know what's going on. You don't remember it. So think about somebody who's sleepwalking. They're kind of bewildered, they're confused. And if you ask them in the morning, do you remember what happened? They have no recollection at all that that happened. So now let's go a little bit further and let's look at what are typical examples of non-REM sleep. So remember, we're still at the first part of the night. And classic examples of non-REM parasomnias like sleepwalking typically happen in children. So you think about, gosh, here's my little story. Gee, doc, tell me when it happened. It started when I was a kid. And here are some examples. So confusional arousals. You think about your child waking up in the middle of the night, confused, bewildered, not knowing what's going on. You don't really need to wake them back up. Don't worry, sweetheart, just get back to sleep and you'll be just fine. And that's a confusional arousal. Sleepwalking, we talked about that. A sleep terror, we're going to talk about that a little bit better, of waking up with this horrifying terror and panic at night. But again, you don't recall what's going on. You're kind of confused. You're still in that sleep state. And they're classically seen in children, but in a small percentage of the population, they can persist into adulthood. And that's when I start seeing these patients. Now, here are some other brand new non-REM parasomnias that have been described in the last couple of years. They're very interesting. So eating, we talked about that, getting up and eating something in the middle of the night. And look at that last one called sexsomnia. So what a great name, huh? So sexsomnia means doing something while while you're asleep, having to do with sex. And we'll talk about that. It's this abnormal sexual behavior that happens at night, and it's thought to be a correlate of sleepwalking or confusion at night. And patients don't have any recall. And if you look at them under a sleep study, they actually are asleep when these things are happening. So let's go a little bit further. Remember, we talked about this. We go to the first part of the night. Now let's look at the latter part of the night. Remember, we talked about more REM sleep, more rapid eye movement sleep, more dreaming. That's towards the last several hours of the night. So you have more REM sleep. Now, here's something that's very interesting that most people don't realize. When you're in REM sleep, rapid eye movement sleep, you're dreaming. Your brain is very active, you're having a dream, but you know what? Your body is paralyzed. Your eyes move, your heart is beating, you can breathe because your diaphragm moves, but you don't move your arms and your legs. You purposely don't do that. We think that you purposely don't do that because you don't want to hurt yourself. And I'm going to show you later on in the talk today how some people lose that ability to be paralyzed when they're in dream state, and they actually act out the dream. So instead of dreaming the dream, they act out the dream. But here's another consequence. So if you think that you're paralyzed and more relaxed in REM sleep, you're more likely to close off your throat. So you're more likely to have severe sleep apnea in REM, rapid eye movement sleep, and so your sleep apnea is worse. And if your sleep apnea is worse, remember I said that those arousals can trigger parasomnia. So that's why we always look for sleep apnea. So we look for REM disorder. So what is a classic REM, rapid eye movement parasomnia? Again, parasomnia, abnormal activity, it's a nightmare. So remember we talked about sleepwalking, bewildered, confused, you don't remember what's going on. But look what happens with a nightmare. You do remember it, you do recall it. Oh my gosh, honey, I was having this terrible dream. Somebody was attacking us, or I remembered something that terrible that happened. my nightmare, I'll tell you, my nightmare is, oh my gosh, I have to take another test. And doctors are always taking tests. And so my nightmare is I have to take a test and nobody told me what the test is. And I got 2 minutes to study for it, and I've got to get an A+, or I'm not going to be able to do what I need to do the next day. So that's my nightmare. And actually, believe it or not, that's a common nightmare in doctors because we're always taking exams all the time. Okay, so here we go. Let's talk about REM parasomnia. So we talked about it. A classic REM parasomnia is a nightmare. We talked about sleep paralysis, waking up in the middle of the night. You can't move. You say, oh my God, I feel like I'm in a coffin. And then we're going to talk about REM sleep behavior disorder. So REM, rapid eye movement sleep behavior disorder. That means that you've had something happen while you're in dream state, and instead of just dreaming, you're actually acting out the dream. So the classic example would say, oh my gosh, I thought I was fighting somebody in my dream. And instead of just dreaming the dream and staying paralyzed, you're punching or grabbing or knocking over furniture. And we'll talk about that a little bit later. Okay, so this is one of the things that we've learned as sleep doctors over the last many, many years, is that we used to think that everything was an isolated sleep state. So you were either totally awake, or you were totally in non-REM sleep, or you were totally in REM sleep. But now we know all these things can overlap. And what's the classic example? So think about it if you're sleepwalking. If you're sleepwalking, you're kind of sort of awake, you're kind of asleep, you're not one or the other, you're kind of both. And this was a big deal for us to understand that these things could overlap and how we would treat them. So what is the sleep terror? We talked about sleepwalking. Let's talk about sleep terrors. So sleep arousal from slow wave sleep, and classically, the patient will scream or cry out with intense fear. So again, one of my other sons had these things when he was young. He used to dream that these crabs that you see on the street of Florida near the ocean would be crawling in the bedroom. And he said, oh my God, the crabs are in my bedroom. And thank goodness he grew out of that. But that's a classic sleep terror. So here's a patient that I had who's an adult. She comes to see me, a health professional, and I labeled this, look at it, it's kind of a funny title, perhaps this is not a good night for a sleepover. And the reason that I said that is she said to me for years and years and years, she would wake up and she would have, oh my God, these screaming, horrifying events in the middle of the night. And imagine if you're dating somebody and you have them sleep over, or you're newly engaged and you're about to get married and you keep having these horrifying events. Well, the good news is she did extremely well with very, very simple treatment. She had had these episodes since childhood. She would wake up with palpitations, her heart was pounding, she was anxious, she was nervous, and all we had to do was give her some simple medications. And I've been following her for literally over 10 years and she's never had another episode. So this is a perfect example of something that can be very, very, very disturbing to not only your personal life, but interrupt all kinds of other social interactions, and very, very, very treatable. Okay, so let's go a little bit further here. And let's talk about sleepwalking. So the classic example of sleepwalking. So what are you doing? You're kind of asleep, but you start walking. Well, why would you be sleepwalking if you wanted to be asleep? Well, because it's a parasomnia and you're doing something that you shouldn't do. Again, I said very classic in children, more common in children where their parents did it, and very common to grow out of it by adolescence. It just stops. You don't really have to do much about it. However, again, this can persist in adolescence and adulthood. So here's an example of somebody who is sleepwalking, and this patient comes to see me with her sister. So why is this concerning? Look where this patient is sitting. She's sitting on a rooftop. And why did I worry about this case? Well, this is a 17-year-old high school student. She's getting ready to head off to college. So why is that a big deal? This should be something to celebrate. Well, her sister, who's a nurse, is very worried about her safety if she's sleepwalking and she goes off to college. Where there's a new phenomenon that's been described by a famous sleep doctor called pseudo-suicide. So pseudo means false, false suicide, where somebody literally is sleepwalking and falls to their death. And what would they be doing? Well, they'd be falling off a balcony of a hotel while they were on spring vacation, or falling off the rooftop while they were at their dormitory. Well, that could be very, very, very scary. And obviously there are concerns that we need to think about this with safety issues for all the different parasomnias, but especially somebody who is going to be potentially exposed to danger. So what are some of the things that we can do to reduce triggers for parasomnias like sleepwalking? Well, you want to increase the total sleep time. So one of the classic triggers for a parasomnia is you're not getting enough sleep. Reduce stress, reduce alcohol. So, oh my God, you know, you think about a college student, all of these things are terrible. They have terrible sleep hours, they're going to sleep late, they're getting up late, they have crummy sleep, they're exposed to stress because it's a new environment, they have to take tests, they have to get ready for classes, do their homework, and they're drinking. So all of those things are triggers. So as hard as it sounds to kind of tell somebody, listen, you've got to kind of do these things, you have to be cautious and careful. This is an important thing because you could end up hurting yourself. And the patients that I've had have been very compliant and done these things. So what could they do? Safety issues. So think about the college student that was going off to college. What we recommend is try to get a dormitory room on the first floor so you're not falling off a balcony. Try to put these door alarms. So go to Radio Shack or online, you get these little battery operated door alarms to put on the door so that the door opens, an alarm goes off and it wakes you up enough so that you're not going to go ahead and do something dangerous like get into a car or fall off something. Okay, so here's some other options. So in children, often we don't need to do anything. You kind of just watch them. You don't have to wake them up out of their sleep and say, oh my gosh, wake up and shake them. You don't have to do that at all. You just have to ease them back into bed, calmly reassure them, honey, don't worry, sweetheart, you're going to be okay. Just get back to bed, give them a kiss and they're fine. And that's usually all you need to do. There's an old wives' tale kind of treatment that we've done for years is that you let the child go to sleep and about 30, 60 minutes later after they've gone to sleep, you actually do wake them up out of a sleep. So they're asleep, you've awakened them before they have the sleepwalking episode. And for some reason that disrupts the sleep cycle enough that it's not going to trigger parasomnia in some patients. And sometimes that works. Now, say it's an adolescent, like we talked about that 17 going off. Well, it's very important. Get enough sleep. Don't deprive yourself of sleep. Safety issues. We talked about safety issues. There are specific medications that we can give for sleepwalking. We try to hold off on medicines if we can help it, but there are specific medicines that are quite helpful. And sometimes psychotherapy and hypnosis can be helpful. Okay, so look for other sleep disorders. Remember, we talked about that. Look for sleep apnea because I have a lot of patients. I'm going to show you through this talk. I have a lot of patients that all I had to do was figure out that they had sleep apnea and treat that, and they did well. Okay, let's go a little bit further. Here's kind of a funny case This was a gentleman that I saw who was a music teacher. And I didn't have to do anything for him, actually. He did very well. And he would wake up in the middle of the night and he would sit up in bed and he would literally be conducting music. Now, interestingly for me, before I went to medical school, I was actually a music major. And so this was very interesting to me. As a music major, I understood exactly what he was saying. But interestingly, he had no recall that he was doing this. He had no recall that it was literally a form of as if he was sleepwalking and he was conducting music. And his wife knew, oh, honey, she'd say to herself, it's okay. He'll be done when he's done with the first, with the first episode of that orchestration, and he'd go back to sleep. And nothing ever happened that was disturbing to him. But here's another case that's interesting. This is an actual case that I had as well. Patient comes to me and says, listen, Doc, I'm waking up in the middle of the night. I don't remember that I woke up. I get up in the morning, and I've done all the laundry. I've folded the laundry, I've done all the laundry, and I hate doing laundry. And this fellow says, I don't even remember doing it. What the heck is going on? Well, it turns out when I talked to him, he had a history of insomnia and he had been treated with a specific medication. Now, interestingly, sometimes with a parasomnia, we actually treat them with the medication to make it go away. And sometimes we actually pull away a medicine because it's the medicine that actually caused something. And it turns out that this fellow had insomnia and he had taken a sleep aid and he had no recollection. And all we had to do was take away that sleep medicine and he never had another medication. But remember, he had no recollection. It was kind of entertaining. Now, I suspect that his spouse actually loved it that he was doing the laundry and maybe would have wanted him to stay on that medication. But the reason that we don't want him to stay on the medication is, even though it was kind of funny and entertaining that he was doing laundry, is, oh my God, maybe he would get up and go cook something or turn on the stove or start using an iron with his ironing or do something dangerous like get into a car. So those are the things that we worry about and we say, oh my goodness, no, we can't let that persist. And that's why we took him off of that particular sleep medicine, and he did very well. He had no more episodes, no further episodes. Okay, so now we talked about this sleep eating. So look at this. This is very interesting as well. Well, it turns out that there are two different kinds of sleep eating. Look what I've called this: a recipe for getting rid of leftovers. So these are actual cases that I see not infrequently. They have been described in the literature for about the last 10 years. So this is a college student, 5-year history of getting up to drink almond milk. I never even knew what almond milk was until my daughter started telling me what almond milk is. Did not remember what was going on with some of the episodes, did remember what was going on with other episodes. Now, why is that important? Well, it turns out that there are two kinds of sleep eating disorders at night. One is called a nocturnal eating disorder. So what's a classic example of that? You go to a restaurant, you have a great meal, you order chocolate cake as your dessert, but you don't finish the chocolate cake. And there's a lot of that chocolate cake left, and you bring it home in a doggy bag. You're at home, you wake up a couple of hours after you've gone to sleep, and you say to yourself, hey, boy, I remember I had that chocolate cake. You go down to the refrigerator, you get a glass of milk, and you take out the chocolate cake, and you're eating it, and oh my gosh, nothing tasted any better, and it's terrific, and you go back to sleep. But you remember that you did it. That's a nocturnal eating disorder. But then there's a disorder called a sleep-related eating disorder, and you do not remember what's going on. So instead of getting up and saying, gee, I'm wide awake, I want to go eat that piece of chocolate cake, you wake up in the morning and you look on your kitchen counter and there's a bowl of Cheerios with Coca-Cola in it. Or there's all kinds of weird stuff that was counters and ripped open packages and things on the counter, and you have absolutely no recollection that you've done it. Well, again, this is thought to be a subtype of sleepwalking, and it's very treatable. So we don't want people to do these things because, again, they can potentially hurt themselves or have problems or have weight issues or those sorts of things. So now what can trigger sleep eating? Well, we talked about the same thing as that adolescent going off to college. If they have insufficient sleep or fragmented sleep, look for another sleep disorder like sleep apnea. Alcohol is just poison to sleep. So why is alcohol bad? Alcohol lets you go into the first stages of sleep, but actually fragments the whole rest of your sleep. And alcohol can make sleep apnea worse because it's a muscle relaxant and a respiratory suppressant. So it suppresses your breathing and it makes it more likely for you to close off your throat. And then we talked about medication effect. There's all different medicines that can be triggered, can do this. I have a patient I just saw this week who has had sleep-related eating for years and years and years. And with simple medication, adding medication, this patient has done very well and has not had further episodes. So look for an underlying sleep disorder like sleep apnea. Look at medication options. You're either going to add a medicine or you're going to remove a medicine. Okay, so let's talk about something very interesting now. This is sexsomnia. So here's my little introduction picture to sexsomnia. We think it's been going on for years, but never really recognized as a true sleep disorder until about the past decade, and it's actually a formally described sleep disorder with an actual code, and it's thought to be a subtype of a confusional arousal. Remember, I said that's a non-REM parasomnia. Typically, patients have no recollection of having done it. It's atypical behavior at sleep, and what are they doing? So they could be taking off their clothes, they could be fondling themselves in bed, they could be fondling their bed partner, they could be masturbating, but look at this last one. So those first ones sound kind of entertaining and kind of a little humorous, but oh my God, imagine if you had a very humble, quiet bed partner and all of a sudden they're forcing themselves upon you in the middle of the night, really forcing themselves. It's frightening, it's scary. But again, this is a very treatable entity, very treatable. And what's interesting, it's interesting but not surprising, patients typically don't remember that it happened, and they're embarrassed. They're embarrassed that it happened. They're embarrassed to say that it happened. But fortunately, as a sleep doctor, I can ask all of these different things. So here's an actual patient that I had, and I labeled this "play with your toys, not with mine." This was a case that was actually very disturbing to the wife. This patient this was a gentleman, had a 4-year history of acting strangely at night. He kept groping his wife in the middle of the night with no recollection. And this was not somebody who was malingering and just kind of pretending to do it. This was somebody who literally had never ever done anything like this before and started doing it. But look what else he was doing in the middle of the night. He was also sleep talking. He was performing this thing. This is a newly described thing. I found this very interesting. He was taking his phone and he was tapping his phone. And what he had actually done is he had sent a message, a text message by mistake, and he had also said he was downloading apps. There were these apps, just kind of, kids games apps, like silly kind of apps that he had no recollection of having done that. And so these things are actually formally described now in the sleep literature: sexsomnia and texting, sleep texting. Now the humorous part of this is, oh my God, you don't want to sleep text something that you didn't want somebody else to see. And the other thing is that, oh my gosh, you don't want your bed partner groping you or forcing themselves upon you in the middle of the night. So fortunately, this patient did well. Diagnosed with these different types of parasomnias: confusion, sleepwalking, sleep talking, sleep sexsomnia, sleep texting, and look what he ended up having: sleep apnea, and ended up doing well by treating sleep apnea. That's all we had to do, was treat his sleep apnea. And again, the arousals from the sleep apnea were triggering the parasomnias. All we had to do was treat him for parasomnia that we talked about in one of our other talks before. He was closing off his airway. We gave him a treatment to open up his airway, and he never had any other episodes. Okay, now here's an entertaining case of a sleep talking and sexsomnia. This is an actual case that I had. So a boyfriend and a girlfriend come to see me, and they're ready to get engaged. True story. And I call this the good news case, the bad news case. So what was the good news? So the good news is the boyfriend says to me, listen, she's reaching out and she's grabbing me in the middle of the night and caressing my hair, and gee, I thought that was really pretty exciting. And then she kind of starts fondling with herself, and she has no recollection of doing it. But the boyfriend thinks this is terrific. He's looking at this and he thinks it's wonderful. But then she starts pulling his hair, and he thinks, oh my gosh, this is going to lead to something good. She's bewildered, but he doesn't care because it's making him feel good. But now here's the bad news. So that was all the good news. Now here's the bad news. She starts calling out people's names, and they're not his name. They're the names of other people. And he says, oh my God, doc, we got to do something about this. This is terrible. It's really very disturbing and upsetting to me. And so, again, this was a very treatable thing. We ended up treating her very easily with some simple stuff. And this is something that I found, just a slide that I put, it made me laugh, because there was an old Elvis Presley. I guess everybody knows who Elvis Presley was. And there was a song that he had that said, if you talk in your sleep, don't mention my name. So that was an actual thing. So I, believe it or not, I had an actual case that was like that song. So, okay, so what are the things that we can do to treat if some bed partner is doing something you don't want, like sexual behavior. Well, sometimes I say to the bed partner, listen, maybe sleep in a separate bedroom until we get this thing resolved. Psychotherapy sometimes can be helpful, and it's not typically some sort of thing that, oh my gosh, you've got an issue and you've some Freudian kind of psychotherapy. It's actually more a therapy just to help sleep habits and not have people have disrupted sleep. And pharmacological treatment, there are actual treatments that we give. And again, I've been saying through the whole lecture, I'll keep saying it, make sure the patient does not have another sleep disorder like sleep apnea because it's so treatable. Okay, so by the way, isolated sleep talking. If people are just sleep talking and it's not a big deal and they're just mumbling and doing kind of saying silly things at night, it usually requires no treatment at all, unless it's disturbing like we talked about. But usually if people are sleep talking or the guy conducting the music, very often, sometimes I'll do nothing. Okay, so here, let's talk about REM parasomnias. We talked about REM, rapid eye movement parasomnias. Remember, that's towards the latter part of the night. It's when you're dreaming. You're supposed to be paralyzed initially while you're dreaming. And if you wake up out of your dream, then you're not paralyzed. But what's a classic thing is a nightmare. We talked about sleep paralysis. Sleep paralysis can occur by itself. It can occur with other sleep disorders. And now I'm going to talk to you about REM sleep behavior disorder. This is something that's only been described in the last several decades. Remember I said when you're dreaming, you're paralyzed. So you dream your dream and you just dream your dream. But if you dream your dream and you're not paralyzed, you actually act out the dream. So if you physically act out the dream, you could do something dangerous. And I have personally had patients who have fallen out of bed, they've broken bones in their face, and they've had terrible, terrible things happen. And it can be very, very potentially dangerous. So we have to make sure that we recognize it and we can treat it. So I'm going to show you some actual examples of some patients that I've had here. So let's go ahead a little bit here. So what is a REM sleep behavior disorder? So we talked about it, it's REM, and it can cause injury and sleep disruption. So here I'm going to try to get this, let's see if I can get this slide going. This is not my case, but this is an actual case by a famous sleep doctor who recorded this case. Let's see if we can get it going. Okay, here we go. Okay, we're going to watch him. I don't know if that sound is too loud. Here, I'm going to mute it. I muted it. So here we're going to watch him, and you watch this patient. And imagine if this was your bed partner and you're watching this patient, and now watch him start to look at him, and here he goes. Here he goes. So he's having a dream. We're looking at the sleep study, and he's in REM sleep. Wrap it up. But look at what he's doing. He's not paralyzed. He's smacking the bed. And imagine if you were his bed partner. So instead of just smacking the bed, he's smacking you. So this can be absolutely terrifying. So let's go to the next slide. And here, let's go to the next slide if I can figure out how to do this. Okay, so rapid eye movement sleep, REM sleep behavior disorder can also be seen as something false. So remember we talked about pseudo is false, a false phenomenon. So we can see REM sleep behavior disorder as an effect of medications. Remember I talked about the guy doing laundry and he was having his behavior because somebody gave him a medicine. It was actually a very appropriate medicine, but one of the side effects of that medication was actually getting up and doing things without remembering that you did it. Well, there are medications, typically antidepressants, that can have you, instead of just dreaming the dream, act out the dream. And what happens to people, typically we see this in men over the age of 50, but it can be seen in other patients. Women can have it typically later in life and from other reasons, but it can also happen from sleep apnea. So again, I keep saying it over and over. Why would it happen from sleep apnea? Well, your brain is giving you this battery jolt, getting you to start breathing again, and it triggers this abnormal behavior. So let's kind of go a little bit further here. We talked about those things. And we can see this in association with what we call neurodegenerative disorders. So there are other neurologic disorders that can be associated with this thing called REM sleep behavior disorder. And I'm a neurologist as well as a sleep specialist. So this is something that I see fairly frequently. Okay, so this is a sleep study. Here's a classic sleep study. So this is just some of the leads. Typically when we do a sleep study, we have 24 different leads. We're monitoring in brainwave activity, we're monitoring eye movements, we're monitoring the heartbeats, we're monitoring oxygen level, we're monitoring muscle movement. So here, let me show you this. This is eye movement. So if you can picture this as if you took your two fingers and you were clicking your two fingers, like you were pressing your two fingers together like that, that's what's happening to those waves, those brain waves, because those are electrodes that are attached to the surface of your skin next to your eye. So it's recording eye movements. And so those eye movements are going back and forth, boom, 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 boom. That's what we call rapid eye movement. And that's what we call rapid eye movement sleep. Now look at the bottom. This is muscle movement. This is the chin. So when we do a sleep study, we're looking at muscle movement in the arms, we're looking at muscle movement in the legs, we're looking to see if something's moving when it should not be moving. So this is a normal brainwave tracing. This is a normal sleep study. So if you look at that bottom there, it's kind of flat. It's not really rustling around too much. The muscle movement is not too much to the patient. Now look at this. Now here's a patient with REM sleep behavior disorder. So this is the patient who I said, instead of just being quiet and being paralyzed, is now acting out the dream. And look at all that muscle movement. Boom, 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 boom. Movement, all that muscle movement jerking around all over the place. So now let's talk about some cases. So here's a case that I see. This is a guy who I start to talk to him, and he comes to me because he says, listen, doc, I've seen 2 other sleep doctors, and they say, listen, there's nothing they can do for me because I snore, and they did my sleep study, and I don't have sleep apnea. And I see the sleep studies, and indeed, he does not have sleep apnea. So I say to him, hey, listen, tell me, what do you do when you go to sleep? Just kind of walk me through, what do you do when you go to sleep? And he says, well, listen, I've been tying myself up. So I said, what do you mean you tie yourself up? He said, and this is not an unusual story, by the way. So he takes a rope, just like a rope that you'd be tying something up like a boat to a dock, and he takes the rope and he ties it around his wrist, and then he slings it around his shoulder, and then he slings it around the bedpost of his bed, and then he ties it in a knot so he's like fastened against the bed. And I say, well, why do you do that? And I kind of can tell what's happening, what's coming up. And he says to me, well, hey, for years, I've been having these violent dreams at night. I dream I'm being chased, and I've fallen out of bed, and I've actually broken 2 television sets. So the classic episode of this REM sleep behavior disorder is somebody, typically a mild-mannered person, dreams that somebody's attacking them. And instead of just fighting somebody off in the dream, they actually physically wake up out of the dream and they're physically fighting somebody, and they're either punching their bed partner or knocking over furniture. This guy was busting television sets. So here we ended up treating him. All he needed was a little medication. This guy I've been seeing for 15 years. And all I had to do, it sounds kind of strange, but with the very first dose on the very first night that I saw this guy, after I saw him rather, the very first dose of his medicine, he stopped having any more episodes and has never had another episode. And that's the classic example of these things. So what's the message from this is these things are very, very treatable by doctors who know how to see these things and are used to seeing them. So here's an actual case that was described in the newspaper. I'm going to show you a newspaper article. And this is a patient similar to one that I actually saw. So here's an article in the newspaper in 2003. This is an actual, I'm not divulging anything terrible because this was a newspaper article. And this was a football player. So he dreamt that he was in training camp, and the next thing he knows, he exploded out of bed and he broke ribs and smashed himself into the radiator. Now, the patient that I had was interesting. I said, geez, so you know what happened to you? How did you injure your face? And he says, well, doc, I was dreaming I was back in college, and I was on the football team back then. And there was this guy on the other team that we were playing. I hated this guy. I always hated this guy. And I dreamt that I was down in my stance for the ball to be hiked, and I sprung myself into this guy. I swore I wouldn't let him get past me. And the next thing I knew, I smashed into the wall and I cracked a bone in my face. So this was a case I actually saw, and again, did very well with simple treatment. Now here's another case that could be very terrifying. This was a case I saw where a gentleman was actually awakening out of bed, and he had had heart surgery. So interestingly, I've had heart surgery before, but thank goodness this did not happen to me. But he had a heart surgery, and he started doing these things after his heart surgery that were strange. And he started falling out of bed and doing these strange things. Now look what he would do. He would sit up in bed and he would point his gun to his wife, like a gun with his finger. And he would say over and over, put it down, put it down, put it down. So he told me he was dreaming again, that somebody was trying to attack him and he was trying to actually save his wife. But what happened, he was actually doing bad things. He actually struck out at his wife, and he had actually bitten his wife in the middle of the night. And oh my God, you say, oh my God, how could somebody do something like that? Well, he said, I was acting out the dream. Oh my goodness, I would never do anything like that. He was horrified that he would do it, but actually remembered the dream like a nightmare. He actually remembered the dream, that he was acting out the dream. But because his brain was no longer preventing that acting out by keeping him paralyzed, he was acting out the dream. And so what we did is we looked for other thing, and we treated him again like that other patient with very, very low dose medicine, and he did extremely well. Now here's a case. This is going to be my last case here. So this is a case, and you think about how many abnormalities in sleep can one patient have. So in one of my other lectures, I talked about in medical school, you're taught, hey, try to give the patient one disease. So they come in with a lot of symptoms. They got a temperature, they got a fever, they got a cough, they've got congestion. Oh, you know what? They've got pneumonia. Treat their pneumonia and they're going to be just fine. Well, you know, in sleep medicine, it's very different. It's very, very common for people to have multiple sleep disorders together. They get a multiple parasomnias together. They can do sleepwalking and sleep talking and REM sleep behavior disorder and nightmares and sleep apnea and all kinds of things together. And you've got to treat them all to be able to help the patient. So here's the case that I called, hey, I'll be there with bells on case. And this was an actual case that I saw. And here, look at these images. So the one on the left is she's smoking. The next is she's wearing a shower cap, and the next she has a knife. So I'm going to show you how each one of these images is important for what was actually happening. So the husband and the wife come to see me, and he says to me, Doc, hey, listen, I got to tell you, this has been terrible. And again, I go through my routine. I say, hey, so what are you doing at night? Well, she's doing all of these weird things. And I'll tell you what I do to prevent it, but it's actually frightening me, Doc, because I don't know how much longer it's going to work. So what are you doing? So I ask him, well, what are you doing? So he takes these, he takes a rope, and he takes the rope all the way into the living room, and he ties it around the dining room, rather into the dining room. Takes it to the dining room, and he fastens the rope around the leg of the dining room table, this big, huge dining room table. Then he drags the rope all the way into the bedroom, and he takes this thing with bells, like Christmas bells, like just like you're seeing in the image there, like you put like a reindeer around Christmas. And he puts these bells and he ties them around his wife's waist at night. And then he ties the rope around her waist and ties it. And I said, what are you doing that for? He says, well, I'm going to tell you what she's doing at night. And it frightens me, but I figure, well, my goodness, if she gets up, it's going to make the bells ring, and at least I've got her tied to the dining room table. At least she's not going to hurt me. So this is what he tells me that she's doing. So this is a 15-month history where she's doing this stuff, and she's taking showers with her clothes on. She gets up in the middle of the night. She has no recollection whatsoever, and she goes into the shower and turns on the shower, soaking wet, takes a shower with her clothes on, and gets back to bed. At other times, she's taking her clothes off in the middle of the night. Absolutely no reason to take her clothes off, and starts fondling herself. Other episode, she goes into the kitchen and she goes underneath the kitchen. And remember I told you the Cheerios bowl with Coca-Cola in it? Well, she's actually drinking stuff from underneath the kitchen sink. God forbid, thank God she didn't die from any of this stuff. She was drinking cleaning fluids. The next thing is she's taking silverware, polishing the silverware and putting it in the refrigerator. So instead of putting it back into the drawer where the silverware goes, she's sticking it into the refrigerator. The next thing is she's smoking while she's asleep. She's literally lighting up a cigarette and smoking while she's sound asleep. The next thing is, here, I'll show you this. She wakes up in the middle of the night, she gets up, and she's actually with the scissors over him, like the movie Psycho. And that's why he started tying her up with the bells, because she had taken his scissors and she had standing over him waving it back and forth like, oh my God, doc, I think she's going to kill me. And the next thing that I found most entertaining is this is in July that they come to see me. He says, doc, she gets up in the middle of the night. She's taken all the Christmas wrappings out of the closet and she's wrapping just random boxes and stuff with Christmas wrappings. She was sleep eating. She was cooking at night, turning on the stove. And if he would say anything to her, she would get all agitated and upset and start swearing at him. So what was she diagnosed? You know, again, we talk about how many illnesses can you have. She was diagnosed with sleep talking. She was diagnosed with sleep-related eating disorder. Remember, she has no recollection that she's eating all this junk and crap that she's mixing together. She's doing sexomnia because she's taking off her clothes. She's doing the REM Sleep Behavior Disorder because she's acting out the dream. It turns out that she had actually been in law enforcement and dreamt that she was fighting off somebody. And the next thing is sleep apnea. So, oh my gosh, what did I end up treating her with? She did very well. All I had to do was treat her sleep apnea, give her very, very low dose medication. And she has, again, does extremely well for years and years and years and years. She's had no further episodes. So here, what are some safety issues that you can do for patients who have these abnormal, violent behaviors? Well, if it's really horrendous and I'm kind of scared that, gee, the medicine may not work the first night, I tell them to do things, put cushions on the floor, or under worse circumstances, put the mattress on the floor instead of on the bed. Move your furniture away from the mattress. Some patients actually put themselves in a sleeping bag so they won't get out. Protect the windows, remove knives and guns and all kinds of stuff from the bedroom and the house where they can't get it, and lock it up where they don't know where it is. Lock away the car keys where they don't know where it is. Put door alarms. Remember I told you, you could, if you can't afford like a total house alarm system, you can get online, or Radio Shack, something like that. You can just get these battery operated things you can put on the door, and at least it wakes up the bed partner. Sleep on the ground floor if possible. And I've told you before, if it's really tough, I tell the bed partner, hey, sleep in a separate bedroom until we get these things resolved. Okay, so here are some different what do we do for REM sleep behavior disorder? Well, there are very, very, very effective medications that we use. Highly effective. Remember, I told you very often they work with the first dose or just a little bit of adjustment. Here's some very clever things that we do. They've now come out with a bed alarm. You know, years ago they had a bed alarm for kids who would be bedwetting, and it would the moisture would set off an alarm. Well, there's actually an alarm that you can purchase that, instead of taking medications for these abnormal violent behaviors at night, if the patient starts to get a little bit of restless, it triggers a recording. And it sounds silly, but they've done research where if the wife records and says, honey, sweetheart, don't worry, you're just having a bad dream, just relax, be calm, go back to sleep, that can be very calming to patients and let them get back to sleep. Obviously, you want to have it with a spouse who has a very calming, relaxing voice. The other thing is service dogs. I actually have it, there's been in the literature that service dogs have been beneficial for patients who do things like sleepwalk or do these violent behaviors. And I actually have a patient who had to have his service dog was actually doing this. Now, this was not like to get you through the airport. This was actually helped him to prevent these violent behaviors at night. So what are the different lessons that we've learned today? Well, you can have multiple parasomnias at the same time, and they can coexist. You have to observe safety issues, and there are very, very, very effective treatments. So here, look for underlying sleep apnea. We always say that. And here, what do you want to do? You want to have a good night's sleep. You want to feel better during the day. That's what my job is, to try to help people have a better night's sleep and feel better and have a better life and more healthy life. So I'm ready for, I think we have a couple of minutes for questions if anybody has any questions.
Thank you so much, Dr. Grant. That was excellent presentation. So yeah, we do have a couple questions. Let me just pull them up here. I was taking notes. I have, is insomnia hereditary?
Okay, so insomnia can be, it's not directly hereditary where you say, oh my goodness, my mother has it, so now I'm going to have it, but it tends to be familial. So it's there's a difference between hereditary and familial. So familial means it's more common in families. Hereditary means we can actually diagnose it with an actual gene link. Now, a lot of things, like restless leg syndrome, where people get up and they have restless legs, they've actually identified actual genes that are associated with that. But insomnia tends to be familiar. It's not uncommon at all for patients to say, gee, my mother had it, my father had it, my sisters have it. Sleep apnea can be familial, very, very, very common. And as I mentioned, some parasomnias. So certain parasomnias like sleepwalking, you're more common to have it if one parent had it, even more common to have it if both parents had it. So it can be. And the point is that all of these things are very, very treatable. And it's not unusual for me to have a patient who has sleep apnea, insomnia, and sleepwalking. And then I've got to figure out a way to treat all of those things and make sure that the way that I'm treating each individual thing, it's not making another thing worse, that I want to make them all better. So yes, it can be familial.
Perfect. Thank you so much. And then I have kind of a little story. So my husband exhibits REM sleep disorder behaviors, but is aware that I am next to him. Just thinks I'm with him whenever he is in his dream. Should I be concerned if he is not violent towards me, but he does fight, run, swim in his sleep?
So that's a very good question. So the question was, if everybody didn't hear it, my husband's doing certain things at night, part of a dream, should I be worried? So the easy answer is, gosh, no, you don't have to be worried if somebody's doing a little bit of flailing, or if, say, that person who was conducting music, that's all he ever did. Maybe that's not something to worry about. What we do worry about is, could that herald that the patient's going to do something more serious? So very often what we see is patients start out with mild things and then they escalate to more serious things of falling out of bed or hurting their bed partner. So it's important to at least talk to a sleep specialist about it. And the other thing that's very, very important is, we said that you have to look for something else like sleep apnea. And the most important thing is, if he has sleep apnea, sleep apnea is a risk factor for high blood pressure, a heart attack, a stroke, for diabetes. So if there's sleep apnea that's triggering these episodes, not only are you going to help prevent the violent episodes, but you're going to also help to prevent these other illnesses too. And the other thing about REM sleep behavior disorder, there are non-prescription medications that we use, and there are prescription medicines that we use. So sometimes it's very, very simple to treat. So if he's doing things consistently, I would probably mention it and think about seeing a sleep doctor, because sometimes these things can escalate.
Perfect. Thank you. And then I have another question. Do scary or horror movies create sleep apnea or other sleep disorders?
Okay, so the question was, do scary movies create a sleep disorder? So no, they won't create sleep apnea, and they won't create restless leg syndrome, and they won't create those sorts of things. However, the typical thing that we've all known is, oh, my child saw a scary movie and then woke up and had a nightmare, or was waking up in the middle of the night with confusion. So anything that can disrupt sleep could theoretically trigger a parasomnia. It's not going to cause sleep apnea. It's the other way around. Sleep apnea could cause the thing, but a scary movie could interrupt sleep. I have 10 grandchildren. One of my adolescent granddaughters loves horror movies, which is surprising to me, and it doesn't bother her at all. But her brother can't watch them because he'll wake up and have things. So obviously it won't cause sleep apnea, but it could cause disruption of sleep that could look like insomnia, or be disruptive and cause drowsiness the next day, or nightmares at night. So that's classically what you would see.
Thank you. And then I have another in the chat, says tips for reducing night terrors.
Okay, so there are actual medications, but non-medication use would be all the things we talk about it. So we use this catchphrase called sleep hygiene. So what sleep hygiene means is good, healthy sleep. So the answer to good, healthy sleep is try to get 7.5 to 8 hours of sleep. It sounds silly and it's hard for people to do. Most adults who are working hard get like 6 hours or a little bit more. But when you're getting very little sleep, that can trigger parasomnias, especially if you get poor sleep one night and then you're trying to make up for the next night. And that's classic in people, what we do between the weekend and during the week. The other thing is stay away from alcohol right around bedtime. So if you got to have your alcohol and you say, gee, I want to have my wine with dinner, okay, have it with dinner, but don't have it right before you go to sleep, because alcohol is classic for triggering it. The other thing is there are different medications that we talked about, and you may need to review medications with your doctor of whether to remove a medicine or whether to add a medication. And then I keep saying it over and over, is to make sure that there's not sleep apnea.
Perfect. And then I have, looks like just one more question. And if you guys have any questions, you can, last minute questions, you can put it in the chat box of the Q&A. I have a question here that states, why do I jolt myself awake just as I'm falling asleep?
Oh, that's a very good question that I hear very often. So the question is, why do I jolt myself with this jolt right when I'm falling asleep? Well, it turns out that as you're transitioning either into sleep or out of sleep, it's very common for the body. Remember I told you that we've realized that there are these transitions between wakefulness and sleep, and they're not exactly totally isolated from one another. So there's a very, very common phenomenon called the hypnic jerk. So hypnic, H-Y-P-N-I-C. That means around sleep. So if you think about hypnosis, you're kind of sleepy. Hypnic jerk means as you're going into sleep, you have a jerk. And it's a very, very common normal phenomenon as you're transitioning from wakefulness into sleep. Usually you don't have to do anything about it. It's just reassuring to the patient it's not really a big deal. Sometimes I have patients who will say, oh my gosh, it's driving me nuts. It's happening all the time. And then I have to think about more complex ways to treat it. But usually it's a very common thing. It's not dangerous. And we see it very, very often in the general population. And it's classic the way that person just described it as they're transitioning into sleep.
Thank you. And I do have some more questions that just popped up. So it says, my husband uses a CPAP with a chin strap. Air is still escaping from his mouth and puffs out going air. Is this a problem?
Okay, so this was something we talked about in another lecture. This obviously isn't Parasomnias, but here's the answer. So we worry about mouth breathing only for a couple of reasons. So if there's so much mouth breathing that it's waking up the wife, then that's not good. If there's so much mouth breathing that it's waking up the patient, that's not good. If there's air blowing out and it's blowing into the eyes, that's not good. However, if all that's happening is that's going on, but there's enough air that's going down through his airway to keep the airway open and get rid of the sleep apnea, and if otherwise he's comfortable, and if otherwise he's sleeping well through the night, then I wouldn't worry about it. If it's got any of those things that are worrisome, there are literally 100 different masks and 100 different things that we can do to try to alleviate it. But if it's just doing those things, but otherwise the patient is doing well, I wouldn't be concerned.
Thank you. And then I have another question. How do you explain?
Oh, yeah.
Yeah.
No, I'm here.
How do you explain when having a horrible nightmare, the person sleeping ends up with their body tightening, entwined like a pretzel, arms crossed across the chest? They may have been making a noise in fear of waking up their partner. So how do you explain, I guess, the tightening of your body?
So that may be a combination of a nightmare or a combination of a nightmare and a REM sleep behavior disorder. So if you just think about it, if you were trying to protect yourself from being hurt, you might actually get yourself in a fetal position or in a position to try to guard yourself against whatever was trying to attack you. So remember I said in a typical nightmare, you're paralyzed in the nightmare. So you're not moving. You have the nightmare, but then you wake up and you say, oh my God, I had this terrible nightmare. But if you're physically moving your body, then something is happening in that, and it's probably a protective mode to do it. Now, there are very simple things with that. One thing is don't worry about it. It may not mean anything. And the other thing is to make sure that it's not something else that needs to be treated either very simply or with more complex issues. But it may be nothing. But again, it may be a combination of two different kinds of REM behaviors.
Perfect. No, so those are great questions. Thank you, everybody. And
thank you.
Yes, I'd like to thank you, Dr. Grant. I just put in our chat box a link to our website again at events.baptisthealth.net. And for more presentations like this, Dr. Grant will actually be presenting again next month on September 24th at 11:30 a.m. So we hope that you can join us again. And is there anything else you'd like to leave us with today, Dr. Grant?
No, but it's always, I kind of leave this message all the, first of all, with the COVID virus, be safe, be healthy, you know, wear a mask, you know, make sure that when you're out that you're social distancing, that you wear a mask and be careful and safe. You know, we as health professionals know to do that. You know, I've got health professionals myself and in my family, but it's important for all of our patients and our general population to do that. But the other thing about sleep medicine is be aware. The first thing that I was saying is, oh my gosh, you hear about all these screwy things happening at night, but they're all very treatable. So if you have any questions about your sleep, ask your primary physician, and if you need to, they can refer you to a sleep physician, because this is what we see all day long. And the answer is many, if not all of these things are very, very, very treatable and can really improve your sleep and your lifestyle. So again, have a healthy night's sleep and a healthy day. And again, I wish everybody well with what's going on with everything here.
Perfect. Thank you guys, and thanks for joining us today. Have a great day.
Okay. Bye-bye.